Okay, I'll let you know when we have a full house, which is usually in about 90 seconds or so. Probably just another 30 seconds. And Danielle, if you can hear me, I'll communicate with you through the chat, but if not, I'll shoot you an email. And I think you can take it away.
Great. Hi, everyone. I'm glad to welcome you back to class. Today's class, in my mind, is especially important, and I think all of our sessions have been interesting and brought great faculty to the course. But today we're going to focus especially on patients and caregivers' experiences in managing people who were infected and suffering from COVID-19. When Ingrid and I started planning the course, I think we realized immediately that you can't study a problem of pandemics and disease without placing right at the center the experience that patients, their loved ones, their families, their communities are experiencing. And this really reflects a major change in medicine over the last 30 or 40 years, where there's been a major attempt, at least since the 1960s and 70s, but then accelerating in the 80s and 90s, to place patients' experience at the center of attention for physicians, for other healthcare providers, in thinking about what happens when any of us get sick. And so that's our plan for today. This emergence of what we sometimes call patient-centric care or shared decision in medicine and health is really one of the major transformations of medicine here in the US and around the world over these last decades. We could trace that history. It has a lot to do with patient advocacy and activism in AIDS and HIV, in breast cancer. But this class really recognizes that shift where you can't start to understand what a disease means and what to do about it without understanding how patients think and feel and experience it. And one of the central aspects of this has been taking seriously patients' stories and narratives and really listening to those stories, understanding them. And this is not only important for patients, it's been incredibly important for people who care for them, and also taking seriously physicians and other caregivers' stories about their experience caring for patients. And in my own mind, it's changed healthcare in many excellent ways, despite the deficits that we still see. So I'm really pleased we just have some excellent thinkers and guests who have had very complicated and difficult experiences during the pandemic, just in these first 8 months. And I'd like to turn it over to Ingrid to introduce today's speakers and move right ahead. Ingrid.
Thank you so much, Alan. So as Alan mentioned, we have some very special guests today. We are not going to do our usual poll since we want to allow enough time to have this conversation with our guests and also allow enough time for all of you to ask your questions. So as always, please put your questions into the Q&A. We'll try to allow enough time to get through a whole bunch today. We're going to start this session today with a man who needs no introduction for everyone in this classroom, President Larry Bacow, who's going to be speaking with us in two roles, both as the president of Harvard University and also in his role having faced COVID himself, both he and his wife. So he'll be speaking from a very personal account as someone who has dealt with the virus. We'll next have Dr. Daniela Lamas, who is a physician at my hospital, Brigham and Women's Hospital. She's an intensive care unit attending. She's been writing extensively for the New York Times on her experience as a care provider in the intensive care unit. And we have a very special exchange today that she'll be having with one of her patients who she was caring for in the intensive care unit, Mr. Rahman, who is here with his son today, who has obviously done well, and they'll be having a conversation together, and we'll be getting to hear from Mr. Rahman and his son. And then finally, Dr. Sharon Levine, who is the section head for geriatric medicine at MGH. She's been a leader in the COVID response at the Massachusetts General Hospital, particularly in caring for our older patients. And so we'll be getting to hear from her about her role there as well. So we have a very full session today, and we're so looking forward to having our speakers. I'm going to hand it over now to President Bacow.
Well, first of all, thank you very much, Ingrid. Thank you, Alan, for the opportunity to participate in the class. To all the students, it's a pleasure really to be able to sort of share my experience with you, and I'm very much looking forward to the conversation. Adele and I got diagnosed very, very early on in the course of this virus. In fact, if I recall correctly, I think we were maybe the 9th and 10th people associated with Harvard to be formally diagnosed in terms of faculty and staff and affiliates with the virus at the time. Adele actually had a cough for about a week. She had actually gone to see her primary care physician, who looked at her and said, "Oh, you're fine. You're not infectious." Nobody thought about COVID at the time. This was still in relatively early March. And we didn't think much about it. Her cough seemed to resolve itself and disappear. Then we both developed a cough. We developed fever, about 102 fever, felt like the flu. I had terrible muscle aches, chills, felt like the flu. I called my physician, my primary care physician, who said you might have, coronavirus, as we knew it back then, before we started calling it COVID. And he said, you should get a test. We got in the car, we drove ourselves. I continued to get my medical care at Tufts. I was president of Tufts for 10 years and got a complicated medical history, kept my doctors there. And so I said, how do we get a test? And he said, well, you can just come to the hospital. And so we drove ourselves to the hospital. We stood in line at a walk-in clinic that they had set up for people to get tested. And we got tested. And I mentioned that because there was some debate whether or not we got special treatment. The folks at the hospital had no idea who we were. We were just two more patients standing in line to get tested. And then, of course, we were diagnosed. For us, we were fortunate. It felt like a bad case of the flu. We spent about the next week to 10 days in bed. Then, as our fever ultimately resolved itself, we spent another 10 days to 2 weeks just trying to get our strength back. By the end of the day, we were always beat. By around 3 o'clock, both of us had to lie down and take a nap. I took this very seriously. In 2004, when I was president of Tufts, I was diagnosed with an autoimmune condition similar to lupus. It's not classic lupus, but my rheumatologist said it was lupus-like. And that required me to be hospitalized 9 times over a 6-month period. I spent a total of 30 nights collectively in intensive care at the time. And since then, I've been immunosuppressed to treat this disease. So I took it very, very seriously from the start. And in fact, for the 10 days prior to getting sick, I had literally no contact with anybody other than Adele. We were just isolated in the house. We'd already started working remotely as an institution. So I made a decision as soon as we were diagnosed to be quite public with it, and sent a message to the community, which many of you received. This actually resulted in the one humorous element of this. Adele and I were lying in bed, sick, watching CNN, when Anderson Cooper announced to the world that the two of us had the coronavirus. There are many aspects that are strange about being Harvard, but this is one that is right up there. But I decided it was important to be public, in part because I wanted everybody to take this disease quite seriously. I knew it could have consequences for all of us, that we were all vulnerable, we were all at risk. And I was particularly concerned about vulnerable populations, of which Adele and I were one by virtue of our age. We both just turned 69, but also given my pre-existing condition. Fortunately, we managed to avoid the problems that plagued so many people and landed them in the hospital. And I'll say just one more thing about my primary care physician, which the doctors on the call will appreciate. About 10 days to 2 weeks before I came down with COVID, he called me up on his own and said, you know, Larry, given your history, I think there's more risk for you being immunosuppressed at the moment now than there is not being immunosuppressed. So he actually took me off my Imuran. So I don't know if that meant that I bounced back a little bit faster or whatever, but anyway, if there's a lesson here to the students, it's listen to your doctors. So it's my story, let me stop there.
Thank you so much, President Bacow. I think there are going to be a lot of questions for you, but I think that is an incredibly informative story. And I think it speaks to the wide range of experiences that people have with COVID. And we'll be hearing now from Dr. Lamas, who will be interviewing a patient, Mr. Rahman, and his son to talk about their experience as well.
Hello, and thank you guys so much for coming. So I was on an overnight in the intensive care unit, actually the night before last, and an off moment, and I was walking down the hall and perhaps thinking about this upcoming course. I found myself thinking about how that exact space had been transformed back in March, April, and May. And now I'm taking care of patients with a wide range of critical illness, cancer, sepsis, heart failure. But back then in April, in those same halls, everybody had COVID-19 and everybody was in the ICU for that one reason. And, you know, even now walking down that hall, each room, though I've taken care of many patients in those rooms since, each room still holds the memory of the person who was there for weeks or even months this spring. And, you know, walk in and on the sort of left-hand side, I see the room that will, for me, sort of always contain this young man in his 30s, relatively young, man in his 30s, developmentally delayed. He got COVID in his group home. I'm told that he loved Dunkin' Donuts iced coffee. His family talked to him on the phone each day. They never wanted to see him by Zoom. It was going to be too much for them. He ultimately passed away. Down the hall, there's another room that has about a 40-something-year-old gardener from El Salvador. And we thought he wouldn't make it many times. He actually ultimately ended up doing well, left the hospital, which was sort of remarkable and speaks to what we'll talk about a little bit in a couple of moments, which is, you know, the range of recovery with this illness, the way it's sometimes so surprising. And then round the bend past the nurse's station is the room that for me will always in a way be the room of Mr. Rahman. And it's a room that I hope that Mr. Rahman will get to see, because I understand that that's something that he's been thinking about after our visitor policies calm, hopefully at some point, and this is something that we can do. And so I first met Mr. Rahman this spring, And at that time, he had been brought into our hospital, transferred from another hospital near his home, because he was sick enough that his doctors thought that he might need to be put on a machine called ECMO. So ECMO stands for extracorporeal membrane oxygenation. And essentially that's a long sequence of words that mean it's a lung bypass machine. When lungs are sick enough that they sometimes are from COVID, that the ventilator itself is not enough. And so by the time I met Mr. Rahman, he was on ECMO, which requires one to be deeply sedated. So we didn't talk. And I had talked to his family on the phone. And one day, ECMO is remarkable, but it has some potential for negative effects. You need to be put on blood thinners so that the blood doesn't clot in the machinery that takes the blood out of the body, puts oxygen in it, takes out carbon dioxide, returns it to the body. And patients on ECMO, because they're on blood thinners, sometimes they bleed. And this is what happened one day to Mr. Rahman. And so I called his family. At that time, the visitor policies meant that families could only enter the hospital when there was a real chance that the person that they loved might die. And so calling a family and asking them if they would like to come in brought with it a whole, a significant, it meant something very significant, obviously. It meant that there was a chance that it wouldn't be okay. And so I called Mr. Rahman's family and asked them if they wanted to come in. And his son, who you will meet here, he came with his mother. And I'm wondering if I can sort of give you guys the floor for a little bit to tell me about what it had been like to be on the other end of those calls. Obviously, Mr. Rahman didn't know that this was going on at that time, but what it was like to get those updates from us and what it was like to enter the hospital that day. So you can go ahead.
Hi, I'm Mushvik. I'm Mr. Rahman's son. And it was a tough spring this year. I still remember the dates, and I feel like I always will throughout my whole life. It was a life-changing moment that I had in my life. My dad went to hospital on April 15th, and he got transferred to Brigham's that night. And he was on a ventilator for a week. Before he went on the ECMO, we got a call that he's doing a little better, and that was a little bit of light of hope. And I still remember on April 23rd, we got the call that his lung collapsed and he went on ECMO. Since then, I have been worried like I've never been worried before. I don't know how to describe it actually. And since then, like every day we would get a call that he's not doing any better, he's just stable. And that was that little bit of light of hope in the darkness. And on May 8th, we got the call from Dr. Lamas that he's bleeding out. He might not have 2 hours or maybe an hour, so we should get there as fast as possible. And we just didn't know, me and my mom and my brother, my sister, everyone else, we didn't know how to process that. We needed a minute. And Dr. Lamas asked for some time to make sure that he's not going to survive or survives. She doesn't know yet. And that time was the longest 30 minutes or an hour for everyone in my family. Like it was a time in distress. But we got the call that he pulled through, and we don't know where it's going to go, but we can go visit him. And that was a good feeling, because at least we knew that he pulled through once. And I had the hope that even if anything happens again, he's going to pull through again. And I knew it, because he pulled through this time. Nothing's going to stop him the next time. And we went in there, and I didn't feel a lot of emotion because I had the feeling that he's going to come back. I met Dr. Daniela Lamas and her workers and nurse and everyone. And I had the feeling of hope. I met a great team, which was helping my dad. And it was a great feeling. And since then, I knew that he's going to come back. And I felt happy about it. It was much more easier than those last 2 or 3 weeks that he was in the hospital, since I met his team in person. and saw him after a month, it was much better. But after a couple of days, we got a call again while I was sitting on the same spot that I'm talking from, the spot that I'm talking to you right now, that they need permission from us for them to not resuscitate him if his heart stops. And the thought just blew my mind, because my parents always taught me to not give up, and they were always talking about goals in life. But this was family. How could I tell them to give up if it just stops? So I didn't say anything, but with the HR, with the social services and everything, they took the permission from my mom and my sibling that they're not gonna do anything if his heart stops. And it was one of the worst times. And every day for that whole week since then, it was May 12th, and up until May 20th, we got the same call that he's doing worse and worse. And I had the chance to see him twice more, actually. And the last time I saw him, I still didn't feel bad. Before I left, I told him, "Dad, we got this. Just give it one more last shot," while he was still unconscious. I put my hand on his chest, and the nurse said his lungs are not capable for him to live, but I could still feel his heart beating. So which was that tiny little hope I was talking about, that tiny little bit of light in the darkness. And about 2 or 3 days after that day, after I visited him, we got a call from the doctors that there's still a little bit of chance, so they're gonna give it one last shot. And since then he started improving. It was May 20th, we got the call that he's getting a little better. So they're gonna try one last time. It was pretty hard, but it was a journey, and it changed how we look into this world, and how life is really unpredictable. That's about it.
Thank you. I mean, it's so, thank you. And like as a critical care doctor, we form these really intense relationships often with families. And in COVID, that was different. These relationships were born over the phone or on Zoom. And I think there was something huge lost. And exactly as Mushvik is saying, like having a family there at the bedside, being able to see the doctors, to meet the people who are taking care of your loved one, these people who we ask you just to put this blind trust in, without actually being there, without seeing them. I think there is something lost. And so I worried about when I met you that day, Mushvik, about what it would be like for you to be there to see your father. And it's really interesting and important sort of for me to hear that gave you the trust that these people who you didn't know were doing the best that they could. And I think that's powerful. And for me to meet you was something extremely powerful as well, and something that was lost for so much of COVID. There are so many patients I took care of, and often people are lying on their chests. I never even saw their faces. And so I just wanted to ask, sort of in the remaining couple minutes, for Mr. Rahman to share, as the time passed and it became clear that you were actually going to live, that you were going to make it out of this, I think our questions changed, and they became not will he live or die, but what will life look like afterwards? And I would, that's a question that so many of us are facing in our own lives right now, right? Like what comes next? How are we changed? And so I would love you to just tell us a little bit about what it has been like to re-enter your life, to be, back home, and what sort of lingering issues from this virus you're still dealing with.
Thank you very much for that, Lamas. Give me the space for talking something in my life, fighting with the COVID-19. So at the April 10th, I get a fever, and the temperature is like 103 and 4 with my younger son. But I don't have any memorized after that, but I'm lying. I'm walking, I'm getting everything, but I don't have any memories to say what happening that time. But 15th of April, my daughter has called the ambulance, and 2-3 minutes ambulance is coming, and they're saying you can go to the ambulance in walking, and or like need a tracer. So I said I can walk, and I'm walking in the ambulance, and near about home, the Salem's hospitals, they're appointed over there. So after that, I don't have any memory. I don't have any history in my mind what I said, because everything is knows my family. And like 16th of April. But unfortunately, is a bad history in my mind in the hallucination.
Mm.
This hallucination is everything is like clear in a life. And someone's doctor has said, is my younger son with me? And he said, I'm gonna kill him.
Oh my
I'm
God.
very scared in this moment. And I took out him. Unfortunately, my symbol language. So he gonna get out in the hospital. And after that, he said, I'm gonna kill you. What is the reason? I'm speechless that time. I can say anything. Only one nurse, she gonna help me. She is looking me, and she did not say anything because he's senior with him. That's why she did not say anything. And after that, I don't know exactly date or month, what is that? So I'm thinking when I get the change in my ICU room, someone is coming, then I woke up. And first target is, he is a man or woman. If I get the man, then I'm looking his face and something, his motion, because I'm very scared about man, because man, he said, he gonna kill me. And after that, I come back in a home. I discuss about with my family. Family has said, this is nothing. This is the hallucination. That's time I get a big hallucination, but I can't believe this is the hallucination, because this is like very live. It's very live what I am seeing. So that's my life is very scared every single moment when I'm in the hospital. Then I go to the rehabilitation center and I'm feeling better. Like and rehabilitation center, OT and PT has said, why are you gonna come in the hospital? I said, I get an accident. And this is the hallucination also. I get an accident, that's why I am in the hospital. And how many days in the hospital? I said, they're asking question, what is the date today? So I said, April 17. But unfortunately, that was the June 17. And my rehabilitation center PT is Nancy. Nancy has said, this is June 17.
Yeah.
And you know, when is coming this winter in the USA? I know, this October, November. He said also summer has gone. Then I'm scared again. So how many days I'm in the hospital, but I don't know. Then after that, I meet with my wife in a hospital, rehabilitation center, Spalding. So I ask her question, why the hospital is long time, but I don't know about, I don't have any memories, but my family is know everything.
And I think, thank you for sharing that. And I think sort of what you're describing is really sort of powerful and is an experience that's shared by both survivors of coronavirus and, intensive care. When people are sick enough to be intubated, sedated for a long time, there are these hallucinations. And it's so important for us to follow these stories. There's a temptation when somebody leaves the ICU to say things are good, things are over, but it is so important for us to follow these stories, to know the sort of long reverberations and the tail of this illness. And I'm so heartened that you're home, that you're doing better. But obviously, as we can all tell, these are improvement will take a long time, and working through what you've been through. And so thank you. To me, the story of coronavirus will always have your sort of face and your son attached to it. And so it's so powerful to see you again in this setting. And thank you for sharing your story and for, telling everybody else what you've been through as well. So I'll turn it back to the group. I hope that you can, stay for questions as they come.
Thank you three so much, really, for that incredibly powerful story of your journey. And as I turn it over to Dr. Levine, I'd love to pose a question that's coming out of that. Maybe Dr. Levine, you might be willing to answer this as well, which is, as physicians, a lot of times when our patients are critically ill, the families, their loved ones, whoever's there in the hospital, is such a critical reminder of their humanity. And I think not only is that toll so severe for the patient, but it's also severe for the healthcare providers who are caring for these patients, who get to know them and understand their story. And so I'm going to pass it over to you, Dr. Levine. Maybe in that context, you might have some thoughts as well.
Do you want me to answer that question before I start my talk? Because I think it's...
I would be grateful. Thank you.
Yes. So I think what you're saying is incredibly important, because patients and families or their caregivers or the people who love them and care for them is really, really important. And one of the really hard things during this pandemic has been the isolation of families, parents with children, sisters and brothers with their sisters and brothers, and the inability to have that connection. It's also been very hard to have communication with physician caregivers or medical staff, and it was one of the hardest things for me as a person who was had a parent that had COVID, to be able to. I was living the same thing. I couldn't reach. I couldn't connect. I couldn't find out, and that's not. How do you have trust if you can't even talk to the people? And trust is everything, right? Trust is everything when you're sick. Trust is everything for the people that are giving you care. And trust is everything when you have decisions that you have to make and you want to make sure that they're attended to. So it's been one of the very high touch areas, I would say, of caring for patients, is dealing with their families, dealing with the patient. So I talked to a 103-year-old patient the other day who has not seen, she moved up here. She's got all of her marbles. She was a nurse. She moved up here to be near her daughter, who was in assisted living, and has been trapped there for 6 months. And another patient who decided to leave assisted living and go be with her daughter, so, and just in case this happened. So people have been bereft. Now they sort of meet like in Deep Throat in dark garages, outside the building, with, being socially distanced. But it's been very, very, very hard. Social isolation has been one of the, even in people who are fairly healthy, the social isolation of this pandemic has been, if you can play bridge online, yeah, that's good. But if you're living with 10 other people in a few apartments and you got to go out every day and then come back to your family in a densely populated place, it's really hard. So I think it's a really important question. I'm going to talk about it when I talk about what we've been doing. It was a lot of phone calls. It was a lot of videos. It was a lot of Zoom visits. And it was my telephone box was filled every day trying to help people not feel scared and help them feel like it was going to be, we were working hard to make these connections for, like, Mr. Rahman's son, who was, how can this be happening to my dad? And I can't even see him. I can't talk to him until I can, but I'm in a hazmat suit, you know? So it was a very challenging part of this illness, and remains so.
Thank you.
Did that answer your question?
Yeah, thank you so much.
Okay. This is a big topic, and I think it's a microcosm of your course. And you'll understand why when I start talking. So I want the students here, who I can't see, to just close your eyes for a second, or just think for a moment about a really special older person in your life. I want you to think about a teacher, a grandparent, a family member, a neighbor, and as I'm talking to you, okay? So, by far the strongest predictor for death in COVID is age, and age alone. And even though people who are 65 and older are 16% of the population, soon to be a quarter, not too long from now, they account for 80% of the deaths. This is my mom, Anna Levine. There she is with her little lifeline around her neck. You remember that? Help me, I can't get up. That's what that is. And she's with my husband. She was 88 in this picture, and she died during the epidemic. And so I was living what I was doing with my patients and all the things I was going to tell you. But geriatricians love stories. Geriatricians love their patients. They have joy in practice. I'm sure that Dr. Lamas can tell you this. And what we spend our time doing with our patients is talking to them about what matters to you. What matters to you in life? What matters to you if you get sick? What are your goals of care if you get sick? And we really want to know what those things are before the fact rather than after the fact. And I was very lucky that I talked to my mom about this. I had talked to her about this many times. She had all of her marbles, and that will figure into the story that I'm about to tell you. So not only is it a predictor, but it's a predictor for hospitalization. So the older you are, the more likely you are to be hospitalized and much more likely to die. And there are several reasons for that. But one of them is that people like President Bacow might have underlying conditions. They may have heart disease, lung disease, they may be on immunosuppressants for other diseases. They may be morbidly obese. And the more conditions you have, the higher your risk is of being hospitalized and of dying. This is a really important slide because this is a slide about what the microcosm is. And I'm going to focus on two areas of this. One is community and one is the interpersonal. Ageism is one of the remaining big isms that we do not address in our society. It's incredibly important. And this is like, you smell bad, you can't hear, you can't see, you're slow, you're taking my seat on the train. And there's a tremendous stigma against older adults. I think we have to address that, and I won't go into that in this conversation that we're having. But the other is this interpersonal question that you brought up. So social isolation was really, it was just, people had to call, they had to connect, they had to be reassured, and they needed caregivers, and they didn't have access to their caregivers, especially the ones who didn't have families who were their caregivers. So this was really, really, this all led to a lot of the vulnerabilities that older adults have. The other issue was, and I want to bring this up because it's really important, and it's in the newspaper, this is hot in the press right now, in the spotlight that's going on in the Boston Globe. 42% of the deaths occurred in nursing homes and assisted livings. And there were many reasons for that. It was even greater in Boston. It was 64%, that scale across the top, the darker it is, the more deaths there were in nursing homes. Nursing homes are where people go for rehab, like Mr. Rahman did after an acute hospitalization, or they break their hip and have to learn how to walk a little bit better. And there's another population in nursing homes, which are people who have lost their independence to be able to stay in the community, and it becomes their home. It's where they live. And the second is paid for by Medicaid. The first is paid for by Medicare. Assisted livings are not nursing homes. There are not nurses all over the place. There's a personal care person who helps you get bathed and dressed and get ready for the day and maybe gives you your medicines, and you live in a little studio apartment. But if you get sick, there are not millions of people around you. You are living in an environment that was closed. People were not allowed in, people were not allowed out. If you went to a hospital, they wouldn't let you come back to your assisted living. And so the families could not get in. And people who are of a certain age don't know how to use iPads, iPhones, FaceTime, Zoom. You saw a lot of this when you tried to talk to them on the phone. So it was really a challenge. The issues in the nursing homes and assisted livings was that this wasn't this was not every one of these facilities, but several, was that there was no PPE. Their infection control policies were on a scale of not too existent to very existent. There was questions about cohorting of patients to separate those with COVID and not. There was very limited testing. There was staff, the clinical nursing assistants who work in these institutions are Black and brown mostly. These are minimum wage jobs, about $14 and change an hour. They work 2 or 3 shifts at different places or in patients' homes. And so a lot of them brought disease in, or they got disease in the homes doing this incredibly frontline work. And I will tell you, as a caregiver whose mom was in one of these places, you couldn't get in touch. You couldn't reach a nurse. You couldn't reach anybody. And I'll tell you the story of my mother afterwards, but it was very frustrating and scary at the same time. Families could not find out what was going on. And patients, when they came into the ED, came with no records, no healthcare proxies, no medical directives, even though they had been done. So this was, everybody knew this was coming. One tree catches fire, and very soon there's a big fire that has to be put out, and it's impossible to put it out, and there's a conflagration, and that's what happened in a lot of these facilities, and it was ruinous, and it was ruinous for patients, and it was ruinous for families, for all the reasons that I talked about. And patients, when they were in the hospital, people like Mr. Rahman didn't really want to go. I mean, Spalding is fantastic, but and he's young, so he was able to really be mobilized. But people didn't want to go to these facilities because they were scared witless that they would wind up becoming sick or catching COVID, because they read the news too. And just this Saturday, at the Holyoke Soldiers Home, the medical director and the superintendent were indicted for criminal neglect, because what happened is when they had staffing issues, they cohorted their dementia patients together without looking at their COVID status. So they had COVID and non-COVID patients mixed. 76 patients died in this facility. So this was really happening. And this was happening at my mother's place. And I will tell you about that when we get to that. People who are homebound were even in some ways a precarious position also, because the patient on the left, you can't go to your daycare, your adult day health center, where your doc may come and visit you, where nurses take care of you and check your blood sugar, where you get your meals, where you have your social activities, and where you have your life, and you come and go to every day. They're closed. You're home. On the other side of this picture is a patient who's dependent on a personal care attendant to come in the house and bathe him and dress him and groom him and have a relationship with him. And his meals are delivered and his laundry is taken out. And all of those things become a big Megillah, because you have to have PPE that you can wear. You have to socially distance. And so these patients were scared also. And if they got sick, they were worried that it would be a real problem for them. And because they were scared that they were going to get COVID in the hospital in early days. And they were also scared that that they just didn't want to come in. So if you had 103.5 temperature because you had a gallbladder infection, but you didn't know it, you didn't want to go to the hospital. And yet we spent a lot of time talking to people about this, about saying why it was important to go to the hospital. But as you know from the news, a lot of people didn't want to. It was very, very important to talk to people during this time about their advance directives. On the pink is a MOLST form. It's Massachusetts Orders for Life-Sustaining Care, so people could express their wishes about what they wanted. Did they want to be resuscitated? Did they want to be intubated, go on a ventilator like Mr. Rahman, or did they not? They had had a good life. Or the daughter might say, my mother has advanced dementia, and what is she going to gain? And I'd say, well, I have to tell you, you won't be able to visit her, and you're her lifeline. People will be in hazmat suits. You won't be able to have a conversation with her. It's going to be very disorienting to her. And what about if you took her home? And what about if we took a hospice approach for your mom? And we talked about all those things. Geriatricians love to talk about death because, you know, it's really part of life. 25% of my patients die every year, and I don't mind going there. And I didn't mind going there with my own mom. The healthcare proxy was very important. Who was going to make decisions if patients couldn't do this? And so all of these conversations were going on at the same time. And it was so high touch. We had town halls. We had a little loneliness group for the unbefriended, because there are truly unbefriended people who have no one in their lives and no one who can even be a healthcare proxy when you talk to them about that. So we just talked a lot with patients. If they got COVID, we called them. If they wouldn't come in to be tested, we kept them home. And if we could get testing at home, we did it. We called them every single day to see how they were doing, no matter how many patients we had. This was a lot of phone calls. And we just kept having serious illness conversations. The kinds of conversations I had had with my mom when my mom was, you know, this was a year ago. She had had one stay in an ICU, was intubated. And I said, Mom, you've made yourself full code. Every time you get sick, you don't want to go. They want me to reverse this. She said, no, I don't want to. I said, okay, what is resuscitation? She said, oh, they push on your chest, they give you shock. I said, yeah, what else do they do? She said, they put that plastic tube down your throat and they put you on a respirator. She said, I already had that and I'm alive. So I said to her, Mom, you know, if you have cancer and all over your body and you can't, and you're going to die from that, do you want to be intubated? Do you want to be resuscitated? She said, no. I said, if you have a big stroke and you can't interact with people, which is the most important thing to you, do you want to have that? And she said, no. So I knew where I was when COVID came. Here's my mom. This is when she's 85 on the steps of the Supreme Court during the Windsor decision, the oral arguments for the Windsor decision after the Defense of Marriage Act was enacted. She was like a total diva there. And we took her down there because it was also the 50th anniversary of the March on Washington with Dr. King, which she went to all by herself as a young housewife. And my mom was a political junkie. She was watching the Biden-Bernie, you know, debates in the primaries. She went to college when I was in medical school. She went to law school when I was a resident. And this is her at the age of 61 at her graduation with a friend, the guy with the hat, and then walking across the stage with her 3 grandchildren at the age of 63. And then my sister, for her 80th birthday, scored 2 tickets for the Obama-McCain debate at Hofstra. And I think that was the highest point of her life. And so she was someone who was very engaged in the world, but made crappy decisions, including staying in a lousy place, refusing to come up here where we could be with her, being with my sister. And it was very difficult. So what happened was in March, they closed down the nursing home she was in. It was not a great place. She liked the food. But I immediately, when that happened, I went and I tried to talk to people about reversing her code status. And I said, listen, if my mother gets COVID, I want her to be, do not resuscitate, do not intubate, do not hospitalize, comfort measures only. It took me weeks to get through to the medical director. And I made him promise me that they would do that? And he said, yes. And so I reversed her code status, but it was impossible to talk to her for that entire time from March until the end. On April 7th, we got a note that there was a COVID case in the nursing facility. And there were 2 cases. One was in the hospital and one was on the floor. And that was cohorted. And I knew that that was it. And that's when I reversed her code status. I had already reversed her code status because I knew that this was likely to happen. And I was living this. And I had heard from the doctor who was the medical director. He said, I'm in a war, I'm in a war, I'm in a war, I'm in a war. You have no idea. And when I got called on April 14th by her nurse practitioner, and she said she was crying for the first 5 minutes and could not talk to me. And she said, your mom is sick. Your mom's oxygen saturation is very low. And I think she's really gonna die. And she just kept crying. And I waited till she stopped crying. And I said, thank you so much for telling me. But I couldn't talk to my mother. And I was absolutely unable to get through. My mother would not deal with the iPads the couple of times that they tried. And she knew she was dying because she said to the aides with whom she had become close, I know I'm dying. You've been very good to me and I would like you to come to my funeral if you can. And can you please ask my daughters if they'll come too? And that was a terrible thing to hear because, it was, I think what she was trying to do was trying to distance herself from us so that she could die. And she was diagnosed with, she had low oxygen on April 14th. They had no testing. They invited my sister in. There were no masks. The nurses aides were wearing Johnny coats, not gowns. And the charts were piled up on the desk. They were empty. The rooms were empty. My mother was one of the few patients on the floor. And she died. She died about 2 weeks later. They tested her eventually a couple of days later because once they got the tests. And they treated her adequately. They gave her palliative care. And that's, I felt so happy, even though she was in this terrible place, but that she had people who cared about her there. And she died. And my sister, it was a Zoom funeral, and my sister took this picture because this shows the magnitude. My mother's grave was one of many. If you look down that whole row, it's one new grave after another. And my sister was there with my brother-in-law and my nephew and his wife and the rabbi and the grave diggers in the hazmat suits. And that's how we said goodbye to her. They dressed her without clothes. They put her in a casket with nothing. I always wanted to put her law degree in her casket. And I have still yet to get her belongings. I don't have them, and no one can answer us, and the entire staff has turned over for the 4th time since my mother was there. So I was living this with my patients. I understood it. I got it. I knew what the frustrations were, but I felt so blessed that I knew what my mother wanted, because I said to her, Mom, and what if they want to send you to the hospital and you say you won't go and they call me and say what to do? She says, you decide. So I did. I decided, and I felt fine with my decision, and my sister felt fine with my decision, and that's all that really counted. And those 2 little girls that were walking across, when my mother had colon cancer 10 years before she died and she recovered, it was stage 1. The surgeon said to her, what's the most important thing? What matters to you most? And she said, to see my grandchildren gainfully employed. And there's one who's an urban planner, the other one who's an assistant principal in a South LA public school, and her other grandchild is a lawyer. And so I think that she would have been very, very happy. She was very happy and very proud of them. And I only wish she had had a chance to vote in this election. That's my biggest wish, would have been for her to be able to take part in voting, but she was very good at doing. In this picture, she is about 88 also. So that's my mother, and that's my double helix of caring for patients and being a patient advocate for my mom as well as my patients and what it felt like. And I understood it and I got it and I'm okay. Because I think that I honored her wishes, except for that she stayed in a really crummy place, which as a geriatrician was very hard for me.
Dr. Levine, I really want to thank you. There is, in telling stories like this of, one's family and eventually loss, something just so generous. And I have to say, I found all of the discussion, if there's one word that characterizes both these exceptional caregivers and these patients who have had experiences that they have agreed to share with our class, is a sense of generosity. And I know that the best caregivers always understand that. And, I've had very good medical care, and many of the things that people have said about trust and resilience and recovery and the character of caregivers' relationships with their patients are at the center of this. And all of you weren't here last week, but we recognized in the class that 200,000 Americans had died actually during the hour that we were in class together. And I raised the question, how do we make sense of this? How do we take a big number like that, or the number that you see in today's paper of 1 million deaths worldwide, and try to make sense of it and give it meaning and to understand what's at stake? And today's presentations really do that. So there are many, I have many questions, but there are many questions from our students, and we have time to bring them on or ask their questions. So I think we should turn to that, and maybe at the end, Ingrid and I will come back with some additional questions. But I just want to reiterate, how important I think this is to be able to understand the human character of illness and recovery and loss. So thanks to all of you, and let's open this up for questions.